Hi, Dr. Guttmacher. So I just saw a patient with a resident in clinic, and he talked a lot about distressing thoughts. And one of the diagnoses on the differential was OCD. I was wondering, like, if you can walk me through your thought process when you see a patient with OCD or with these distressing thoughts.
Sure, Yuri, and terrific you asked. There's no other disorder that I find so gratifying to work with. These are folks who are very much incapacitated in many ways by their illness.
Yeah.
And there's nothing else in psychiatry where people have so much insight. They're aware of what's happening. And they're aware that something is wrong. But they're unable to make the changes they need. And that leads then to lots of humiliation because they know they're behaving in a way that makes no sense.
Mm.
And yet they can't stop. So let's walk back to the beginning and let's talk about what's an obsession.
Yeah.
So an obsession is an unwanted thought or impulse that is recurrent. And those beget behaviors or thoughts that are meant to nullify the obsession.
Mm.
Again, this is illogical and it doesn't make sense. So when this cycle starts to happen, the obsession begets the compulsion. Mm. So let's take an example. Somebody sees a spot on the table in front of us, and they're convinced irrationally, and they know it doesn't make sense, that that spot could cause them to get AIDS.
Mm.
So they sit there looking at this thing, looking at it and looking at it, and then are convinced that it's happened, and they go dashing out now to wash their hands, and they'll wash and they'll wash. And eventually that works and that thought goes away. And so then the next time they see a spot or something untoward, it becomes even easier for that thought to occur. Again, they know intellectually this makes no sense, that you cannot catch it that way. That's a contamination, obsession, and compulsion.
Mm-hmm.
This is pretty common, 1.5% of the population. So with the obsession and the compulsion, and it needs to cause interference in life functioning.
Yes.
So lots of us do checking we don't need to do. When you left the house in the morning, maybe you went back to check whether the door was really locked.
Yeah.
But you did it once and you went on your day and it didn't bother you and it didn't interfere with your life and you got to work on time. Other checkers may be unable to mail a letter because they've got to go in and look at whether it went down the chute or not. And they'll go back 10 times to see if it's there. That's starting to interfere now with their life.
Yeah.
So people come to see me, and typically there's been some crisis that finally got them to do this, and typically this has been around for years before they come in. What I will do is try to get as good a history as I can. What I will do with them in that early session, there is something called the Yale-Brown Obsessive Compulsive Scale, and there's a symptom checklist. You can look up Y-box symptom checklist and it'll show up. And I'll go over that list with them. And that is incredibly important. One, because I start to know the behaviors they have. Two, because they suddenly realize, oh my God, I'm not alone with this. There have been lots of other people who must have this, which helps wonderfully with the humiliation. We now know the behaviors that are the problem for them. And then I do a little basic education. What I point to always is the same example. I asked them to remember the first time they got behind the wheel of a car and what they felt like. What they felt like was wildly anxious. And then I asked them what it felt like when they got behind the wheel today, and lo and behold, it didn't. So what happened? Well, repeated exposure to feared objects leads to their getting better. So I teach them something I call the SUDS, the subjective unit of the stress scale. And I'm going to go through in great detail with them some examples. The SUDS is 0 to 100, 100 being the worst feeling you've ever had. And I'll say, okay, so you worry about that for contamination. Let's go through some other examples. What if you were to do this? How many points would that give you? And let's, again, detail what you've been exposed to. What I'm going to ask you to do is to expose yourself, and we'll do this together in the beginning, to those things you're fearing. And I'm going to ask you how many points you give it, and where do you feel it, and what's it like? And then I'm going to ask you, and at the end of 2 hours, if your anxiety is still so high that you've got to wash or do your ritual, go ahead and do it. Because everybody always, it goes down. It goes up, it comes down. And then I'm going to ask you to do this every day, the same exposure and the rate. And what you're going to find is what is today's 40, is tomorrow's 30, is the next day's 20, is something you can handle. We're going to work our way up the scale with you having that exposure. And so that's the principle of behavior therapy. That's one alternative. The other alternative is medication. Medication's a whole lot easier. It's also a lot less effective. So what the research shows is that on this Y-box scale, that most people, most studies, people are beginning at 28 or 30. And if they go on meds, they get down to 24. Well, that's a lot better, but that's still pretty bloody impaired. We can do that because it's easy. You're going to need more med than you would for depression. It'll take longer to work, but it may be, and there are individuals who have a glorious response. On the other hand, behavior therapy works more effectively. And the bad news for you, I regret to tell you, is this tends to be a lifelong disorder. So you're going to need techniques for future. And the behavior therapy, exposure and response prevention is what works. So, in addition, behavior therapy never really causes anorgasmia. Medications have been known to do that. The side effects are really more benign. But it's up to you where you want to start. If you want to do the behavioral work, we will do this together. I'm going to give you lots of homework. And I'm also going to need your family to come in. Because your family needs to understand this. Because I'm willing to guess that your family knows how much distress you've been in, knows the things they can do to make you feel better. That if, for instance, you worry about they're bringing contamination to the house and they need to take off their clothes at the front door, they've been doing that. That's not helping you. So they need to understand and we need to work together. So family approach, basic exposure and response prevention or meds, and this can get a whole lot better. Any questions?